Hi, this is Conrad Fisher, and welcome to our next section of Physiology. I'm the Associate Professor of Physiology, Pharmacology, and Medicine at Touro College of Medicine in New York City. And the information and the knowledge and the way that we're going to approach this course today is going to be the same as we would do as if you were in front of me in my own medical school right in New York City. It is possible to get every single question right on the physiology section of your Step 1 examination if you follow the principles that we outline for you here today. Let's get started with endocrine physiology. This is Conrad Fisher. This is the longest section of physiology, and the good news is there's no calculations. The bad news is there's volume. But I will tell you something here about endocrine physiology on Step 1. If you learn this now, you're learning almost everything that you need for the Step 2 section of endocrinology as well. So open your brain and let's get started. The first part is that for the ordinary human being, whether a hormone is a peptide hormone or a steroid hormone doesn't matter. For the ordinary human being, for the uninitiated in secret ways, it doesn't matter whether or not it's a steroid hormone or a peptide hormone. You just have to go, yeah, it's a hormone, yeah, whatever. Like, it goes through the blood with the greatest of ease. It makes me secrete from my head to my knees. These hormones are lovely. They go through the blood. They come from an organ and know where it's going. So yeah, that's right. That's why it's called a hormone. It's endocrine because it goes endo, and endo means into the blood. Exo means it's going down a duct. Not a duck, a ducta. Like the pancreas is ducta. Like saliva is a ducta. This is endocrine because it goes through the blood. Even if it goes next door, right next to a cell, even if it goes to a cell that's only an inch away, it's like calling someone in the next room from your cell phone. Still goes up to that satellite tower, doesn't it? That's endocrine through the satellite towers. So you are going to know every single letter in this page. Steroid hormones have to go through the membrane and into the nucleus. In the nucleus, they affect new mRNA. New proteins being formed. That's slow, steroid hormones. That's slow. Peptide hormones are fast. Peptide hormone works through a second messenger. Why do you have to have a second messenger? Well, it magnifies, it amplifies things. It's like a phone tree. I call two people, they each call two people, and they each call two people, and all of a sudden it magnifies the signal through the cell. So peptide hormone touches the receptor. The receptor turns on a G protein. The G protein activates a second messenger. Now, the second messenger, based on what cell it is, could be cyclic AMP or calcium. On the slide in front of you, you see the word IP3. Sounds like a urologist I once saw, called IP Daily. But no, that means inositol triphosphate. Inositol triphosphate, what that does is it phosphorylates things. What's that thing that's called? DAG. Stands for diacylglycerol. Now, diacylglycerol is where we split out a piece of the cell membrane, split out a piece of fat, and diacylglycerol is a fatty particle left behind that activates things. Second messengers are fast because you're not making new protein. You're activating, phosphorylating, and otherwise turning it on. It's like the difference between going out and baking bread from scratch and just going out and activating a loaf of bread. So peptide hormones are fast. Steroid hormones are slow. Peptide hormones have second messengers. Steroid hormones have new protein. Peptide hormones have short half-lives because there's no protein carrier. Steroid hormones have long half-lives because they have a protein carrier. Peptide hormones can be stored in vesicles because they're water-soluble, and steroid hormones can't. They travel on protein carriers. Let's review that. Let's take a look and make sure we know for sure what's the difference between steroid hormones and peptide hormones. Steroid hormones are lipid soluble, so you can't store them in a vesicle. You can't store them in a vesicle because vesicles are made out of fat, aren't they? Yes, they are. The receptors inside the cell goes into the nucleus. New protein, that's slow. Peptide hormones are water-soluble. They touch the receptor. They activate a second messenger through a G protein. That's called signal transduction. Now, steroid hormones, is it based on what it's made of, or is it based on its method of action? Well, it's not what it's made of, although most steroid hormones are derived from steroid. Steroid hormones are based on cholesterol. It's like cholesterol. That's why we call it steroid. Are you a human? No, I'm a man made in the image of a human. I'm a machine made in the image of a human. Android. Are you from this planet? No, I'm human. No, I'm humanoid. Shankroid. Carcinoid. Oh, similar to. So it's from cholesterol, so we call it steroid. Oh, aldosterone is a steroid. Testosterone is a steroid. Progesterone is a steroid. Aldosterone, testosterone, progesterone is steroid. What about this one? Vitamin D. Cholesterol. Cholecalciferol. Oh, because it's from cholesterol. It's calcium for all. Calcium for all. Cholecalciferol. Cholecalciferol. Yeah, that's right. So it's also a steroid hormone. Now, thyroid hormone we list separately because it's not derived from cholesterol. It's derived from tyrosine. But its mechanism of action is still steroid. Lipid-soluble hormones, they get synthesized as they're needed. Yeah, that's true. Then they get stored, like thyroid hormones get stored in follicles. They get transported on plasma proteins, which serve as carriers. That's what gives it a long half-life. Saying long half-life and protein carrier is really saying the same thing, isn't it? Protein carrier, long half-life. Protein carrier, long half-life. Protein carrier, long half-life. And they have a relatively long duration of action compared to peptide hormones, which are stored in vesicles. Now, all hormones are secreted in pulsatile fashion, except, which is the only one that's constant? Which is the only hormone that's constant? Thyroid. Thyroid's the only one that's constant. Which is the only one that's constant? Thyroid is the only one that's constant. That's right. All steroid hormones are protein carriers and lipid soluble, except DHEA, which is sulfated. DHEA, which is sulfated, goes across the placenta, and it's sulfated. Oh. All steroid hormones are pulsatile, except thyroid. All steroid hormones are in lipid carriers, except DHEA. All peptide hormones are water-soluble, except IGF. Insulin-like growth factor is on a protein carrier. Oh, how interesting. That's right. There's one exception. Now, everything is in pulsatile amounts except prolactin, which is shut off all the time. Remember, what is the rate-limiting step in steroids? Is it the amount of the hormone, or is it the amount of the receptors? What's the rate-limiting step? Is it the amount of the hormone or the number of the receptors? The answer is the amount of the hormone. The receptors already have to be out there. You can't say, let's secrete and then build a receptor. Would you like to go and take off in a plane and say, well, I sure hope they build an airport for them by the time it's time to land. Let's make sure there's a receptor. No, the receptor's already there. Well, let's go out there. I've got a set of keys. I hope somebody puts a lock in the door. No, the lock in the door is always there. Protein bound means it's not active. Protein bound is the exact opposite of free. Protein bound means long half-life. Free means short half-life. Steroid hormones are lipid soluble. That means protein bound. That means long half-life. I just said the same thing in 3 different ways. Peptide hormones are free. Short half-life. Easily pissed off. Goes out in the urine. So the liver produces the proteins that bind to lipid-soluble hormones. We have cortisol binding globulin, thyroid binding globulin, sex hormone binding globulin, vitamin D binding globulin, cholecalciferol binding globulin, thyroid binding globulin, androgen binding globulin, cortisol binding globulin. They all have binding globulins. And binding globulins go down when there's liver disease because they're made in the liver. So what do you expect if they're made in the liver and you've got liver disease? I can't make enough binding globulins. That's understandable because they're made in the liver. Well, the other thing is, did you know that estrogen makes binding globulins go up? Did you know that? Oh, really? Yes, estrogen makes binding globulins go up. Well, if estrogen makes them go up, what about androgens? Well, androgens makes them go down. Very good. Exactly right. Estrogens make the binding proteins go up. Androgens make the binding globulins go down. Equilibrium means that there's lipid-soluble hormones circulating in plasma. They're bound to proteins, and they're in equilibrium with the amount of free. See, it's only the free that's regulated. It's only the free that has feedback inhibition. It's only the free that is active. So it stays in equilibrium to make sure that there's always about 1% that's free. That's for everything except calcium. Now, calcium's not really a hormone directly. It's not a hormone. But that's the only exception for that is calcium, because calcium is about 40 or 50% free. But all the other hormones is only about 1% free, and everything is about binding that 1% free to regulate it. The free or unbound is available to tissues, creates the activity, and creates the negative feedback. Only the free have action in this lifetime. Something deeply philosophical about that, don't you think? You can live a long time by being bound up. You might stay safe, but you're not going to do anything while you're all on that protein carrier, are you? Yes, but I'll live for a long time. Yes, but you'll live for a long time doing nothing. The transport of lipid-soluble hormones is in a balance with free hormones. There's just a picture of the same thing I just said. Estrogen binding globulin, testosterone binding globulin. The total hormone is both the bound and the free. So when you have a pregnant lady and she has an increase in thyroid hormone, is that an increase in the free or an increase in the total? The pregnant lady is an increase in the total. The free stays the same. So free, regulated, because free is what can have an action. You can't do anything. If you drive to school in the morning and you stay in your car, you're not very free to do anything, are you? Because the active hormone is the free. The liver is what makes the binding globulins, so therefore, if you have liver dysfunction, you won't make binding globulins. So the circulating level of bound hormone changes and free hormone remains constant. If you bump up the volume, bump up the protein binding volume, the total goes up, but the free remains constant. It's just increasing the binding globulin. The 1% free is constant. So liver dysfunction and androgens decrease binding globulins. They do. That's very easy to understand in the liver, isn't it? After all, where are they made? Ooh, they're made in the liver. Why do female sex hormones increase your level of binding globulins? The answer to that is very simple. I don't know. But pregnancy increases the total amount, but it does not decrease or increase or change the free. The free remains constant. There is tremendous specificity in these hormones. Hormones don't sleep around. ACTH only affects the adrenals. Growth hormone only affects IGF and growth hormone receptors. The only exception to this specificity is thyrotropin-releasing hormone. At conditions of pathologic excess, thyrotropin-releasing hormone will stimulate you to make prolactin. Did you know that? Thyrotropin-releasing hormone under conditions of excess will stimulate prolactin. Now, the specificity of things that ACTH and luteinizing hormone both increase steroid hormones. But ACTH only does so in the adrenals, and LH does so only in gonads, which is to say theca cells for women and Leydig cells for men. Theca cells for women and Leydig cells for men. There's a tremendous specificity of those hormones. Normal rate-limiting activity is the amount of hormone. The receptors are there. The same way the airport's already there. The lock's already there. It's the number of keys. It's the number of planes that determine the activity. Under normal conditions, the receptors are not saturated. Now, it's very easy for students to mistake this with a disease called type 2 diabetes. Type 2 diabetes is an illness. That's where the rate-limiting step is the number of receptors. But then again, that's a sickness, isn't it? The rate-limiting step should be, in normal people, the amount of the hormone. The receptors are there. What's rate-limiting is how much hormone goes up minute to minute. The number of receptors should not be rate-limiting, but rather the plasma concentration should be what tells you whether it works or not. My goodness, what's a ligand? Why do we have to call ligand? Well, ligand is a $5 word for transmitter, particularly neurotransmitter, but transmitter. So abnormalities or events distal to ligand-receptor interaction, transmitter receptor. And resistance often due to a high level of circulating hormone where those hormones will make the receptors down-regulate. Now, down-regulation means that the target involutes, the receptors in the target down-regulate. Now, down-regulation versus feedback inhibition. Which one of those is normal? Down-regulation or feedback inhibition? Feedback inhibition is normal. When you're at a restaurant, it's normal for them to say, would you like anything else? And you do feedback inhibition. Say, no, thank you, I have everything I need. That's different from somebody coming out and saying, I want to sew your mouth shut. That's down-regulation. Feedback inhibition is, no, thank you, I've got everything I need right now. So there's a reduction of hormone levels to recover the sensitivity so that when the hormone level goes away for a while, you can actually regrow some of the receptors. It'll increase its sensitivity. The same way, if you don't have chocolate every day, you're likely to really increase your sensitivity to chocolate. If you have it all the time, it'll downregulate those receptors. Now, tissue resistance means that you've downregulated receptors. There should be, and often is, a normal level of hormone because the receptors are missing. However, you don't have the manifestations of the hormone because you've lost receptors. Downregulation is a disease. Downregulation is also known as tissue resistance. It's a disease. Feedback inhibition is not a disease. Going backwards up the system is not a disease. Permissive action is one of my favorite endocrinologic features. It says that it's not the hormone itself directly, but rather potentiates the effect of another. For instance, one type of hormone must be present for the other to be acting. An example of this is cortisol and glucagon. In order for cortisol to raise glucose, it needs glucagon to be present at the same time. That's permissive action. Another permissive action is cortisol on blood pressure. The presence of cortisol upregulates alpha-1 receptors. The presence of cortisol upregulates alpha-1 receptors, so it has a permissive action on catecholamines. Cortisol has a permissive action on catecholamines. With steroids there, the catecholamines have a greater effect because they're increasing the effect of the catecholamines in the presence of steroids. And the last permissive action is hard for people to remember. Did you know that you needed to have thyroid hormone for growth hormone to be released? Most people don't realize that. You need to have thyroid hormone in order for growth hormone to be released. That's why it is that people who have cretinism, hypothyroidism, never achieve puberty, because you can't have a pubertal growth spurt without growth hormone, and you can't have growth hormone without thyroid hormone. So cortisol and glucagon raises glucose. Cortisol and blood pressure increases alpha-1 receptors. And thyroid hormone and growth hormone. You need thyroid hormone for growth hormone to release. In order to analyze levels, we have to provide a blood sample. Now, hormone sampling is very difficult because If they're all pulsatile in nature, how do you know if something is decreased or elevated? Maybe you're catching them when they're in between pulses and look like they're deficient. Well, you start out with blood levels, but random blood levels are not really very good. That's why you've got to get a 24-hour urine cortisol, which tells you the average over the last 24 hours. You see, blood levels, especially random blood levels, are not the diagnostic test for cortisol or aldosterone because you have to look at them in their 24-hour cycle. All hormones are episodic except thyroid, and therefore if you have a peak or a down or decrease, then it can simply look falsely as if there was a deficiency or an excess. That's why we can't use random levels, because we have to look at the patterns of secretion. Remember that IGF is maximum at what type of day? Insulin-like growth factor is maximum in the middle of the night. And cortisol is maximum early in the morning, just before you wake up. That's what helps us get out of bed in the morning. You get breakfast in bed, out of your head. Woke up, fell out of bed, ACTH came out of my head. Mama went downstairs and got a cup. Cortisol went up and woke me up. And you get a breakfast burrito in bed with glucose and fatty acids. But it's all pulsatile. That's why random levels are not useful. Here's an example of this. Growth hormone. It's secreted in pulses and mainly in the middle of the night. Now, it also has a short half-life. That's why we use IGF levels. IGF levels have a long half-life because we don't want to. How do you go and get a blood sample at 3 o'clock in the morning? You can't. But IGF has a long half-life, and that's why it's different from all other peptide hormones, because it has a protein carrier. Growth hormone is a good example of something that the name doesn't help us. Growth hormone does not cause growth. Growth hormone is a stress hormone. The IGF portion, the insulin-like growth factor portion, that's the protein portion. Now, T4 has a long half-life. And that's why a random measure of T4 is good. Why? Because it should be up for a long time. It should be up for a week and stay up. So thyroid hormone is the only thing where we can measure totally at any time without regard for the cycle of the day. It should be up all the time. Urine analysis, to be able to look for the hormone levels, is really just for catecholamines, some steroid hormones like 24-hour urine cortisol, and occasionally some water-soluble things like HCG and luteinizing hormone. But the major thing that the urine is for is 24-hour urine catecholamines for pheochromocytoma and 24-hour urine cortisol for diagnosing Cushing's disease or hypercortisolism. Now, when we're looking at an integrated sample, remember 24-hour urine free cortisol gives you the average over the last day. And it's often needed to diagnose a certain low-level amount of hypercortisolism and eliminates the variations, because when you go through the urine, the metabolites are there, so it averages out. 24-hour urine cortisol is like saying, hey, give me the 24-hour averages, man. Hypofunction can be hard to diagnose because in between peaks, everything looks like they're hypofunctioning. Autoimmune diseases. Well, we don't really know what causes type 1 diabetes. We think it's an autoimmune disease in someone who is genetically predisposed, but it's better to say we don't know. Hypothyroidism is definitely autoimmune because it's burnt out Hashimoto's thyroiditis. Antibodies attack your thyroid, then the antibodies kill off and strip the thyroid, and Hashimoto's thyroiditis is kind of an autoimmune thyroiditis. Autoimmune is also the most common cause of Addison's disease. It used to be infections, but the infections that used to do it, like tuberculosis and pneumococcus, like tuberculosis and meningococcus, are vanishingly uncommon. So 90% of Addison's disease is autoimmune, primary immune deficiency. And gonadal failure just happens. Now, the other thing is tumors can displace the gland, hemorrhage can infarct the gland, or you can get it damaged by infection. Stimulation tests are a way of being able to tell whether the target organ works. For instance, we can give ACTH stimulation and see whether or not by giving ACTH the adrenal gland works. You take the cortisol level before and after ACTH. Now, when we want to really test to see whether the pituitary is insufficient, we can actually give them something like corticotropin-releasing hormone and see if there's a big bump up in the ACTH level to make a diagnosis. However, if you don't have a hormone being made, doesn't mean that you're deficient, but failure of growth hormone after giving arginine, that is a sign of real deficiency, because arginine is an amino acid which should stimulate growth hormone. Why would we want an amino acid to stimulate growth hormone? Well, there's two reasons. One, in the short term, if we make a lot of excess arginine, or we ingest a lot of excess proteins, one, we use them to actually make muscle and make protein. But number two, if we don't need to make any muscle or protein, arginine, like proteins, is converted into sugar. Then it goes into triglycerides and it's put into storage. This is one of the ways that we understand, it's a little bit like pulmonary, that excess proteins become fat.
Now let's look at some endocrine system disorders like hyperfunctioning. Now, hyperfunctioning can be caused by hormone-secreting tumors, hyperplasia, autoimmune stimulation, or ectopically produced peptide hormones. And this is evaluated by suppression tests. You see, you can't evaluate hypofunctioning by suppression testing. You can't evaluate the absence of something by trying to suppress it. You evaluate overproductions by suppression testing. In acromegaly, we get an IGF level first, but then we look to see if glucose can suppress the growth hormone. Hypercortisolism has a range of suppression tests. We have a 1 milligram overnight dexamethasone. Normal should suppress. The abnormal won't suppress. And then we have low-dose and high-dose dexamethasone suppression testing to tell us the source. 1 milligram overnight dexamethasone says, do you have hypercortisolism? High-dose dexamethasone says, where's it from, man? The pituitary suppresses, but ectopic doesn't.
The men syndromes, or multiple endocrine neoplasias, can be hard to memorize together. In other words, is it really that you have to know the difference between men 1, 2, and 2B? Ooh, probably. So men 1 with the hyperparathyroidism, so that's why you'll go looking for calcium. Endocrine pancreas tumors are usually functional. They usually oversecrete one hormone. And pituitary adenomas. Now, you can have an isolated overproduction of almost anything. You can have an isolated overproduction of ACTH. That's Cushing's disease. You can have an isolated overproduction of thyroid hormone. That'd be rare, but it can happen. So you can have isolated overproductions, and those are called adenomas. Are cancers functional? No. Cancers are not functional. That's why they're cancers. They're not functional. If it was excess function, we wouldn't call them a cancer. Men, too, is thyroid medullary cancer. You wonder, how did that get in here? Because that's not really an endocrine problem. I don't know. And pheochromocytoma, look for episodic hypertension, 24-hour urine catecholamines, or hyperparathyroidism, which is just high calcium and high parathyroid hormone. And finally, 2B, thyroid cancer should not be functional. Thyroid cancer should just be hanging out there being malignant, should not be functional. Thyroid cancer should not be over-secreting thyroid hormone. Pheochromocytoma is functional.
Understimulation of an endocrine gland causes a reversible atrophy. That's reversible because you didn't cut the blood supply, you didn't cut the nerves, you didn't cut the stalk. It's just understimulation. Now, a long-term, high doses of glucocorticoids will suppress the ACTH adrenal axis. This is when they'll present the patient to you that is admitted for asthma, and you say, hey, Dr. Fisher, do we have to taper these steroids? You go, no, because 5 days at full dose and stop. 5 days at full dose and stop. Why? Because it's not long-term enough to have suppressed the axis. You need about 2 weeks to suppress an axis. Overstimulation of an endocrine gland can cause cell proliferation, hypertrophy, and hormone overproduction. An example of this is Graves' disease, where overstimulation of the thyroid causes cell proliferation. Now, goiter does not by itself mean that you have overproduction. Goiter can be overproduction, normal production, underproduction. It can be, this thyroid gland is too overproducing. No, this thyroid gland is too underproducing. Oh, this thyroid is just right. And it can all be goiters. So goiter by itself does not tell you the type of functioning. It just says, your gland is so big. In Graves' disease, it does mean overproduction because you have a thyroid-stimulating antibody. Tumors can create hyperfunctioning, and generally those are adenomas. What caused an adenoma? Adenoma? I don't know. And it may produce no hormone depending on the size of it.